So this afternoon we'll be discussing implantable device therapy in heart failure, what, when, and how. I am Dr. Taiwo Efi. With me is
Dr. Bruno Obokofe. So just give us a brief moment.
okay. Before we proceed, we have an outline. So before we discuss the implantable cardiac device in heart failure, we need to know what heart failure is. So this is our outline: introduction, overview of heart failure, diagnosis, management. What are these devices? The type, indication, the procedure, and then conclude. So heart failure is a major growing health problem worldwide, affects about 64.3 million persons globally. Hypertension is an important cause of heart failure in the African American populations, and then rheumatic heart disease remains a major cause of heart failure in Africa and Asia, especially in the young. Epidemiology varies within and between countries. The International Congestive Heart Failure Study, INTERHEART-CH study, showed that hypertensive heart disease was a common etiology in Nigeria, Uganda, in Mozambique, and overall, and ischemic heart disease was found to be the most common in South Africa and Sudan. Okay, so the etiology of heart failure from the entire study shows that hypertensive heart disease is the commonest overall in Africa, and then Nigeria has the highest rate, while ischemic heart disease was found to be commoner in South Africa.
So it has been shown also that 1 to 2% of adults are heart failure patients worldwide. The admission rate is at least once a year, and then heart failure with reduced ejection fraction is the commonest phenotype worldwide, about 50 to 60% of cases. And also, it has been shown that almost 74% of heart failure patients are suffering from at least one comorbidity. As we know, heart failure is a progressive disease. It's an annual mortality rate of about 10%, and the main cause of death are sudden cardiac death or organ dysfunction due to hypoperfusion. Also, 30 to 40% of patients die within 1 year of diagnosis. And then patients with the New York Heart Association class of 2 have an annual mortality rate of 5 to 10%. Functional status is an important predictor of the patient's outcome.
Okay, the definition of heart failure, we have definition, the current American College of Cardiology Foundation defines heart failure as a complex clinical syndrome that results from structural or functional impairment of ventricular filling or injection of blood, and this in turn leads to cardinal symptoms of dyspnea and fatigue, and edema and wheals. According to European Society of Cardiology, heart failure is not a simple pathological diagnosis, but a clinical syndrome, meaning that it has signs and symptoms. Cardinal symptoms include breathlessness, ankle swelling, fatigue, and this may be accompanied by elevated jugular venous pressure, pulmonary calculus, and peripheral edema. It is due to structural or functional abnormalities of the heart that result in elevated intercardiac pressures and/or inadequate cardiac output at rest or during exercise. Okay, and it results from an imbalance in 3 key neurohormonal systems: the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the natriuretic peptide system. Okay, the natriuretic peptide system has a protective function which counterbalances the detrimental effect. One of the most important adaptations caused by this is as a sort of drop in cardiac output. And when there is drop in cardiac output, which occurs early in the course of heart failure, the activation of sympathetic nervous system is accompanied by concomitant withdrawal of sympathetic tone. So the activation of sympathetic nervous system is to be able to restore the decreased cardiac output so that the metabolic need of the heart can be met. However, When this activation becomes more, then it becomes deleterious to the system, and then heart failure progresses. Okay, this is just a schema showing us what happens when there is heart failure, there is cardiac module to injury due to hypertension, myocardial infarction, and this leads to activation of neuroimmunal imbalance. And this neuroimmunal imbalance leads to ventricular remodeling. The ventricular remodeling leads to electrical instability. So the cardiac dysfunction that results can be systolic or diastolic or both. Systolic means the inability of the heart to contract and eject blood, while diastolic is the inability of the heart to take in blood, and both can coexist. Okay, the pathogenesis is heart failure is a progressive disorder, and it is initiated after an index event that cause damage to the heart muscle, result in loss of functioning cardiac myocytes and disruption of the ability to generate force. And this cardiac event, this index event can be MI, can be PE, can be pressure overload. So when the inside the initial index event occur, so the activation, the compressive mechanisms are activated vis-a-vis the parasympathetic, the RAS, to restore the cardiac output. Okay, so by restoring the cardiac output, this becomes maladaptive, and then we cause secondary damage. And then you can see the heart that is small before now increase, and then the ejection fraction drop. So patient become will be asymptomatic at the initial stage, and then become symptomatic. Okay, this is the schema showing the etiology. Like I said, hypertensive disease remains the commonest. Other etiology include valvular disease, pericardial disease, myocardial disease, and the likes. How do we classify heart failure? Based on ejection fraction, based on superiority, distance superiority, and based on cardiac dysfunction cause.
So based on the echo we have, based on the injection fraction, we have heart failure with reduced ejection fraction when the EF is less than 40%. We have heart failure with preserved ejection fraction when EF is more than 50%, and heart failure with mid-range ejection fraction when between 40 to 49%. Based on functional classification, we have class 1 to 4. Class 1 is when there is no limitation of physical activity. Person goes about his normal activity and there are no symptoms of heart failure. Class 2, when there is slight limitation of physical activity, they are comfortable at rest, but ordinary physical activity results in symptoms of heart failure. We have class 3, when there is marked limitation of physical activity, they are comfortable at rest, but less than ordinary activity causes symptoms of heart failure. And they'll have those class 4 who are symptomatic even at rest. Based on the AHA stage of heart failure, we have class A to D. Class A are those at high risk of heart failure. They have hypertension, they have diabetes, but they have no structural heart disease or symptoms of heart failure. For class B, they have the structural heart disease, but they have no signs or symptoms of heart failure. And class C, we have the structural heart disease with signs and symptoms of heart failure. And they'll have the class D, those who have refractory heart failure requiring specialized interventions, which are the devices we'll be discussing today.
Okay, like I said, just to remind ourselves what heart failure is. So what are the symptoms? I'm sure we've seen a lot of these in our practice. They come with shortness of breath, swelling of the leg, fatigue, and weakness. So they have dyspnea or topnea, they have weakness, they have tachycardia, they have juvenile on examination, you can see their JVP elevated, you can picture that sign. So this is a clinical manifestation. So how do we investigate? We investigate by doing echo. Echo is invaluable in management of heart failure. It helps us to check the chamber sizes, to check the valve function, ejection fraction, to check whether there are wall motion abnormality, and then to do global longitudinal strain. Okay, then the management. Want to reduce preload after load, giving a furosemide, torsemide, metolazone if the edema is refractory. We treat the neuroimmunal abnormality with valsartan, candesartan, and then we give ARNI. The angiotensin ARNI is preferred, but ensure is to be given 36 to 48 hours to allow washout if you are changing from ACI, or 24 hours for ARB. So we should never combine this drug. Why? Because we need to give the washout time to reduce the incidence of angioedema, the patients. Then we treat other neurohormonal abnormalities with giving the mineralocortical receptor antagonist spironolactone, eplerenone, then beta blocker like bisoprolol, carvedilol, then give SGLT2, empagliflozin, dapagliflozin. We may consider atosobide, dialysis, or ibrabadine in some patients. Okay, what are the 4 pillars of HF treatment? We have the ACI, or honey, beta blocker, the MRAs, and SGLT2. So these are the guideline-directed medical therapy. And studies have shown that patients that commence on this guideline medical therapy, they have significant reduction in their mortality at 24 months. We can see that okay, we can see the reduction in mortality, okay, and the relative reduction in all-cause mortality. So patients that have heart failure should be placed on guideline medical directed therapy, the honey, the beta blocker, the mineralocortical receptor antagonist, and SGLT2. So all these have shown to improve overall mortality in the patient. Okay, then we treat etiology. If it's hypertension, we give hypertensive drug. If it's chemical disease, we give beta blocker. Then if the patient will need intervention. Cardiocare is a center, a center of excellence in cardiovascular medicine. We do angiography for patients with stents. So we can refer your patients to us if your patient has ischemic disease. Then treating precipitant is very key, because if you are not identifying precipitant in these patients, they will not get better. So if the precipitant is arrhythmia, atrial fibrillation, flutter, you need to give antiarrhythmic drugs. If it's infection, you need to treat it. If it's fluid, you have to direct your patient to her. If it's electoral arrhythmia, you have to correct electoral abnormality. If it's uncontrolled hypertension, so we have to control the hypertension. So finding and treating the precipitant is very key, especially in acute presentation or whatever stage of presentation they may perform. So they're optimizing other cardiovascular effects. So blood pressure, blood cholesterol, we give statin, blood sugar, we give their diabetic drug, or some may require insulin. Uric acid, you give your allopurinol, episostat. In proteinuria, you need to investigate kidney function in them well. So for diet and lifestyle modification is also key. Alcohol cessation, smoking cessation, treating comorbidities. In COPD, you may want to give them inhalers. In CKD, they may require dialysis. So treating comorbidity also is key. So then after all this, you need to assess your patient for need for device. If despite good treatment, despite being on guideline-directed medical therapy for up to 6 weeks or 3 months, and your patient is not getting better, so it's time to consider device for the patients. All patients with EF less than 30 to 40 should have a device. So all patients with EF less than 30 to 40 with normal QRS duration should have implantable cardiovascular defibrillator, ICD, while with wide QRS duration greater than 130 or 135 or LBB, they will need CRT. Remember, initially we told us that certain cause of mortality in heart failure patients are sudden cardiac death, and sudden cardiac death has been found to be either ventricular fibrillation or ventricular tachycardia. So device is key. And in my practice, I found out that when your patient beginning to require the job thing, I think you should think of consider them for device. Obviously, just a schema of the device therapy. After you have given them your medication, the guideline-directed therapy, then you've given them all this. Their EF is less. You consider ICD. Then, if their EF is less, and then you can consider CRT. We will talk about this in the next slide. Okay. Okay. So, what are these devices? What are these devices?
So the devices includes the pacemakers, the implantable calibrated defibrillator, the cardiac resuscitation therapy device, and the loop recorders.
Okay, thank you. The human heart, it has an electrical system that tells it when to beat. Sometimes this system fails, causing the heart to beat too slowly or too quickly or irregularly. So in such cases, We may use a device to regulate the heart. Remember, I told us that cause of mortality in heart failure patients, sudden cardiac death. So when the heart begins to beat either slowly, quickly, too quickly, or irregularly, so we need to consider a device for patients. So these devices, like my colleague has mentioned, the pacemaker, defibrillator, sleep recorders, and CRT. So what do they do? Let's talk about them one by one. Pacemaker, what it does is send tiny electric signal to help the heart beat regularly, and it uses when the heart beats too slowly or stops. While ICD shock the heart if it beats dangerously to prevent sudden cardiac death from arrhythmias.
Yes.
Then cardiac synchronization therapy help left and right side of the heart to beat together in patients with heart failure and widening KRS. It's been found that in heart failure patient, because of the left ventricular dilatation, they tend to have the synchrony of the left and right ventricle, so they beat in a desynchronous way. So what CRT does is to bring the heart, the right ventricle, left ventricle, to beat together. So by beating together at the same time, that improve contractility, improve their symptoms, improve ejection fraction, improve their a lot of things, and reverse remodeling. So it's a very good choice. And some people have even termed it the IC that some people have termed those devices as guiding angel devices in heart failure. So talking about implantable loop recorder, recorder will continuously record heart rhythm. It can record heart rhythm up to 4 weeks or even more, and is indicated in patients with infrequent symptoms. In fact, it has been recommended as class 2 recommendation for cryptogenic stroke. So it's very good. We do it here if you have a patient that is complaining unexplained syncope. You have done a lot of things you cannot pinpoint, or their symptoms are not frequent. We had a patient one time like that. He presented with palpitation or an unexplained syncope. We did 24-hour Holter, he didn't show anything. It was a loop recorder that showed that he was having intermittent heartburn. So you can refer your patient to us if you have such patients. So this is the system of okay. I don't know if you can see us. Okay, pacemaker. So this is the pacemaker here. Okay, here's the pulse generator, the electronic circuits, and then the lead system. So this is this system. Okay, so this is the loop recorder that I was talking about. So it's implanted into the patient's chest. Okay, pacemaker, first artificial pacemaker was powered by hand and quick motor. It was invented by Albert Heyman in 1932. The first patient to receive an implanted pacemaker and a lasting 1958 at Karolinska University Hospital in Stockholm. He has lived both the surgeon and the engineer. And the most common etiology of bradycardia leading to pacemaker implantation is conduction tissue fibrosis, and other etiologies are also been found.
Okay, so the pacemaker has two major functions, that's sensing and pacing. So it's coded with alphabets. The first letter where pacing occurs, the second letter where the chamber that is being sensed, the third letter, the way the device responds to the sensed event, the fourth letter if the rate response is active, and the fifth where multi-center pace is employed. However, the first three code letters are used most commonly.
Most commonly. So this coding was referred by a North American Society of Physiology and Electrophysiology, or British Pacing and Electrophysiology Group. So these are the ways, the pacing mode, the first to fifth letters. Okay. Like my colleague has said, A stands for atrium, B for ventricle, and dual, D for dual, and 0 for no. See an example. Okay, this is just what we have discussed. So this is you can see the simple chamber mode, BOO. So we know that this means that the ventricle is spaced, no sensing, and the feedback is no feedback. So let's just focus. So this is just what we have explained. Okay, so what are the indications for permanent pacing? In bradycardia caused by reversible etiologies, maybe electrolyte dysfunction and all, permanent pacing is not warranted. But indication for pacing is based on the severity of bradycardia rather than etiology. For patients with symptomatic sinus bradycardia as a result of medical therapy, it's an indication for permanent pacing if there are no alternative treatment option, typically from sinus node dysfunction and AV block. Sinus node dysfunction can be sinus bradycardia, can be chronotropic incompetence. Chronotropic incompetence is inability to increase the heart as a heart rate as a response to activity of other demands. And exercise testing is the basis for diagnosis. There's sinus arrest. Indication for permanent pacing also include documented symptomatic bradycardia, including frequent pulses that produce symptoms. It is a class 1 recommendation, meaning that patients with documented symptomatic bradycardia should have a pacemaker insertion. The symptomatic chronotropic incompetence is also a class 1 indication. So if you see your patients with chronotropic incompetence, you are liable if you don't offer pacemaker for the patient. Heart rate less than 40 beats per minute, even without direct link between bradycardia symptom and bradycardia. Class 2A recommendation, meaning that it should be considered. The patient with syncope of unexplained origin should have pacemaker. Then third degree and advanced second degree AV block at any anatomical level with symptomatic bradycardia, including heart failure or ventricular arrhythmia, presumed to be AV block, should have pacemaker. And for patients with heart failure with wide KRS, we need what? CRTP. Okay. Then also carotid sinus syncope, drop-in chamber pacing is indicated when ACC of up to 6 seconds or more, and syncope following carotid sinus massage, and patient with tube-induced vasovagal syncope. So when to use what pacemaker? Dual chamber pacemaker is key, is a choice in second degree or third degree AV block, because you are going to pace both the atrium and the ventricle. And it's also indicated in potential AV block now or in future. And they consider CRCP if the KRS is prolonged and patient has heart failure. Then single chamber atrial pacemaker is recommended in sinus node dysfunction with symptomatic bradycardia without AV issues, while you pace only ventricle in setting of chronic AF because no AV block is not needed. So patients with chronic atrial fibrillation will require single chamber ventricular pacemaker. Okay, so this is dual chamber pacemaker. We can see the atrial lead and the ventricular lead, and like we said, used to maintain AV synchrony, used primarily with second degree and third degree AV block. Okay, this is what we have just explained. Okay, we have a leadless pacemaker. Okay, so this pacemaker has no leads. You don't have to put the atrial lead, or so you just put it in the heart, very small. Then we have Parisian and left body branch pacing. The Parisian pacing is when the pacing is direct. When the pacing is directly, the lead is pacing the in-bundle branch block and causing activation of the pacemaker system with subsequent ventricular activation. So this is also good. But we have left bundle branch pacing also, and Cardiocare pioneer left bundle branch pacing in the whole of West Africa and Nigeria. We are the only center doing it. So what left bundle branch pacing does is the pacemaker lead is put in the interventricular septum to pace the left bundle branch block, to pace the left bundle branch. So by pacing the left bundle branch, so it mimics the natural synchronous activity or pacing of the intrinsic conduction system of the heart. So it gives a better response for the patient compared to the right ventricular apical pacing that was done in the past.
So next device is the implantable cardiovascular device. I have one here. Okay. So this is a pacemaker with extra features. The ability to sense, it has the ability to sense and to treat arrhythmias. Function includes primary pacing, anti-tachycardia pacing, calibration, and defibrillator. Remember, we said for those who are at risk of or survivors of sudden cardiac death, they have this to help terminate any abnormal heartbeat, arrhythmias, and so on.
So several studies have favored the use of ICD in patients with EF of less than 30%, MADI trial, CABG patch trial, all of them have favored the implantation of ICD in patients with heart failure. So let your patient benefit from ICD implantation. Send them to us. We have a lot of others that are doing well. Like I said, it's been termed as a guiding angel device, because before any arrhythmia, it has shocked the patient. It has returned the heart to sinus rhythm.
So indications for ICD, we have the secondary prevention, that's class 1. ICD therapy is indicated in patients who are survivors of cardiac arrest due to ventricular fibrillation or hemodynamically unstable sustained ventricular tachycardia. After evaluation, and we see that there is no cause of the event, and also to exclude any completely reversible cause. ICD therapy is also indicated in patients with structural heart disease and spontaneous sustained VT, whether they are stable or unstable hemodynamically. ICD therapy is indicated in patients with syncope of undetermined origin with clinically relevant sustained VT or VF induced at EP study. And then ICD therapy is indicated in patients with AF less than or equal to 35%, and they've had prior MI, who are at least 40 days post-MI or 3 months post-cardiology or PCR, and also they're in New York Heart Association Functional Class 2 or 3.
Okay, so this is the ICD of our patient when he was interrogated. You realize that this patient had VT, later degenerated to VFib, and then the patient was sure. You can see the normal sinus rhythm. Interestingly, this patient is up and about 2 years post-event. That's his ICD, and is a member of heart failure support group. And so, by the way, we have heart failure support group in Cardiocare. So you can refer your patient to us. It doesn't matter whether they are patients of Cardiocare or not. Let them come and benefit. The meeting is usually first Saturday of every month. They meet with other heart failure guests. We give them educational topics. So we make them to be connected. We don't want them to get disconnected from their health caregiver. So we want to tell them that we are interested in their case. They are not in this alone. So they meet with other people. They get encouraged, and they get encouraged. They encourage each other. We follow them up. If we don't see them in meeting, we call them. Unlike when they don't come from clinic for follow-up, I may not know, but we have the register. If you don't call, we call them and find out why are you not in the meeting. So they give us reason. If we need to even call them for admission, we do that, or we encourage them to keep up with their medication that they are taking.
So for next indication for primary prevention, these persons, they have never had any cardiac arrest before. So they have non-ischemic dilated cardiomyopathy, and the EF is less than or equal to 5%. And they're also in the functional class 2 or class 3. Also, those who, like I said earlier, who have had a prior MI and at least 40 days post-MI should also be considered for ICD implantation.
ICD therapy is also indicated in patients with not sustained VT due to prior MI, ejection fraction less than or equal to 40, and inducible ventricular fibrillation or sustained VT at electrophysiology study. So it's a guiding device. So we've mentioned all this. Okay. So this is a picture of ICD. We can see the atrial bracing electrode. We can see this coil is a shock. Is a coil having this shiny is the one that delivers shock for the patient. So when you see patient with ejection fraction of less than 35%, please don't hesitate to send the patient to us to place the patient ICD to prevent sudden cardiac death. You know, I told you that mortality in heart failure as a sort of cardiac death is more than 50%, and it's mostly due to ventricular fibrillation or ventricular tachycardia. Okay, so ICD therapy is not indicated for patients who do not have a reasonable expectation of survival with an accepted functional status for at least 1 year. And even if they meet ICD implantation criteria, patient that you are seeing that, okay, this patient may not survive 6 months, we don't want to, don't want to put. Then it's not indicated in patient with insensitive VT or EF. Okay, it's not also indicated in heart failure class for patients with drug refractory congestive heart failure who are not candidates for cardiac transplantation CRTD. So in summary, indication for ICD in summary, cardiac arrest survival due to ventricular fibrillation or VT, structural heart disease with sustained spontaneous VT, syncope of undetermined origin with clinical significant VT or VF induced at EP study, PF less than 35%, and MHI A class 2 or 3, and after 40 days post-MI, non-ischemic dilated cardiomyopathy, not sustained VT due to prior MI, and also patients, let your patients benefit from the guiding agent device. Okay, so I want to talk about another one, which is cardiac resynchronization therapy. Like I explained earlier, when they have heart failure because of delayed ventricular dilatation, so the ventricle, there is synchrony between the right ventricle and left ventricle. So they are desynchronous, they are not beating together, and then that can worsen their heart failure. So what this does is to make them to contract very well at the same time to improve their function. So by contracting very well, improve their symptoms, improve reverse remodeling, and the patient get better. Okay, so CRT also refers to biventricular pacing or multi-site ventricular pacing. It's a component of modern heart failure therapy for qualified patients. For patients to qualify, it must have widened QRS. Okay, the QRS must be widened. Okay, it refers to simultaneous spacing of both the right and left ventricle. The rationale for this is based on the observation that the process of bundle branch block or other interventricular conduction delays or worsens systolic heart failure by causing ventricular desynchrony and thereby reduce the efficiency of contraction. So when there is prolongation of QRS interval, which occurs in approximately 1/3 of patients with advanced heart failure, this has been associated with ventricular electromechanical delay in the desynchrony. And this has been identified as a predictor of worsening heart failure, sudden cardiac death, and total mortality. So when we are pacing of the left ventricle is achieved by placing the transvenous lead in the lateral venous system of the heart through the coronary sinus. We are going to demonstrate that shortly. Or we place the left bundle branch. So we have pioneered the left bundle branch pacing in West Africa, and we are the only center doing it in Nigeria. And that left bundle branch pacing has been found to mimic the exact the synchronous contraction of both left ventricles. So patients tend to improve better on that compared to the traditional way of putting okay. So this is just an algorithm telling us what to do. This is the device, which device is good for the patient. So KRS less than 120, so we give ICD. So when the KRS is greater than 150, it's a class 1 recommendation. And patients with widened KRS, they tend to benefit, they tend to have better response, yes, compared to others. So we have, this is electrical synchrony, manifests as LBB or RBB, it manifests as, RBB, the mechanical dysynchrony, the heart's not contracting the same way it should. Okay, so his picture is depicted here. Let's see. So let's see this man pushing this. The right ventricle is moving like this. The left ventricle. So the car will not move. So both of them, if they stay in the middle now and push this car, and drive the car, but this one is moving here, so the car will not move. So that is what left ventricular synchrony means. By the time they will put the CRT, so it harmonizes the synchronicity and then the heartbeat well. Okay, so what are the recommendations?
So for class 1 recommendation for patients who have EF less than or equal to 35%, their clearance duration is greater than or equal to 0.12 seconds or 120 milliseconds. They have sinus reading. They are candidate for CRT. Okay. And remember, we talked about the medication. If they have been on GDMT for at least 3 months and then there's still no response, ECG shows white chloride complex, LBB, sinus reading, we should consider CRT for them.
Okay, so this class one A recommendation, like I mentioned earlier, if you see your patient writing KRS and the injection fraction less than 30%, it is a class 1A recommendation, meaning that the patient should have the CRT. Then, with ejection fraction less than 30%, writing KRS, so the patient will benefit from CRT, the most important. So the patient should be offered this. So it's a class 1 recommendation, meaning that the patient should have it. It's non-negotiable.
So for class 2A, the patients who have AF less than or equal to 5%, the clearance duration is the same, but there's also atrial fibrillation. We can consider CRT with or without an ICD is reasonable for the treatment of such kind of patients. For patients with AF less than or equal to 5%, and then the New York Heart Functional Class 3 or ambulatory Class 4 symptoms who are receiving optimal recommended medical therapy and who have frequent dependence on visual person, CRT is also reasonable for them.
Okay, this is just what we have said.
This
is just a flow chart of what we have said. But patient heart failure less than the same QRS in sinus reading, QRS complex greater than 150 is a class 1A recommendation for the patients. So if patients will need pacing, EF less than 40, high degree of block, so patient will need CRTP. Okay, so this is the CRT device. You can see right atrial lead, right ventricular lead. This is this coronary sinus. This is the right ventricle. So the summary. Let's go to the summary. So the indications after optimal medical therapy for at least 3 months. For at least 3 months, patient is not getting better. We have LBB class 1. It is class 1 recommendation is non-negotiable. Patients should be offered. And you never can tell you some patients that you think they can't afford it. Offer it. We have seen a lot of our patients that are on device and they are doing well. It's only when they tell you that they have symptoms that they know that they have symptoms. Improve exercise tolerance. They are not bloated. They are doing well. So
reduce admission as well.
Yes, reduce hospitalization rates. Okay, please. So factors that favor CRT, factors that favor a good response to CRT are female gender, non-ischemic cardiomyopathy, LBD, wide KRS, although incidence of non-responders is about 25%. So there it's good to say this. Some patients will say that because they are on device, they have device, so they will leave out their drugs. No, they should not leave out their drugs. We've seen a lot of them. So they are on they have device, they should still be compliant with their medication. Okay, we have this 57-year-old man with ECG showed widening KRS, anywhere NYHA class 4. NT-proBNP was this. Yes, CRT in May 2020 during lockdown. And it's
much better
is in heart failure support group also. Okay, so this is this thing. So you can see the right atrial lead, the ventricular lead. So you can see this. This is the one. You can see this ventricular lead. So we use this to locate this coronary sinus. This is the CRT of the patient. Okay. Okay, so most of these our patients that have device, they are members of the heart failure support group. So the next meeting is coming up on the 1st of August by 11 a.m. in this hospital. It's free. It's a complimentary gift of Cardiocare to all our patients. It's free. They come around, we talk, we give them educational topics. They are doing well. We follow them up, we call them monthly calls, or the calls can even be earlier than that, depending. Okay, so how do we know the procedure? How do we now insert this pacemaker? First of all, you need to evaluate patients, your patients. You need to do ECG to see any, yes, rewarding carries complex LVP, or if there's any other abnormal reading that is present, AF or AB blocks and all. Then you need to do echo to measure heart function. We look at cardiac structures, we measure their EF. Then stress ECG for stroboscopic incompetence. Then 24-hour Holter to detect aiding arrhythmia, blood test to check for infection, kidney function, thyroid function, and all that. Then you now come to a decision. Okay, this patient is device really needed, but they've said some tests to us that they need the device, and then when after evaluating them, they don't need device, and vice versa. They said some people okay, they are just for athlete, and then after evaluation, this person will need device. So if the device really needed, we need to know. And then the patient prepare for the device. So those questions we need to answer them. What are the pre-procedure planning, detailed history, clinical evaluation, and review of investigation that they come with or the one we have to do. We discuss the patient and the family, discuss the risk, the benefits, the complication. We look at their skin, any evidence of skin infection, because if there is skin infection, it will worsen it will be inoculate the device, and then if the device gets infected, the device has to come out. So we stop anticoagulation if necessary. We stop clopidogrel at least 5 days. With the whole team we meet, the programmer, the cath lab team, all of us we all meet, the cardiologist, we review our supplies, because you can't put patient on the table and then discover that okay, battery is missing, you don't have device. Then we give pre-op antibiotics, we give antibiotics maybe about 1 hour into the procedure. Then we get our pacing system analyzer in place, the programmer, the cath lab must be well activated. We have a checklist, everything we needed, we tick them, okay, everything is in place. So prior echo should be reviewed to ensure no congenital abnormalities are present, no evidence of less-added superior canaval issues. We assess the renal function like instead, population status. In case some patients with renal insufficiency, you can pre-hydrate or give N-acetylcysteine. It has worked for several years. Yes, we hydrate them. And then, so we hold clopidogrel, we discontinue to announce because of risks of pocket hematoma. Okay, informed consent is key. It includes a comprehensive assessment of the patient risk and benefits, and should be tailored to the plan access method, different access method. You can say, okay, this is the access we want to use, the benefit of this. So it's a comprehensive assessment of the patient risk and benefits. Patient must consent. Patient must consent. Okay, the infection control must 100% from scrubbing. In fact, anytime we have a procedure, we normally scrub, we take care of the cath lab, the mopping, disinfection and all. Then from hand washing to draping and all. So infection is 100. Infection control must be 100%. 99% is not allowed, because we don't want to inoculate infection into the pocket, or else that device will have to come out. So the skin preparation, no cream or lotion on the day of procedure, necklaces, piercing object near the upper chest removed. We confirm any allergies to antiseptic, chlorhexidine or iodine. We ensure that patient has been shaved or clipped at the sites, preferably in the ward or pre-op room. We do first cleaning in the ward, then pre-surgical skin preparation and colonization. Sometimes we even add them to bath with red thing. So the patient position in theater, we position the patient in supine position to expose the infraclavicular region, and the arm on the implant side is tucked or abducted slightly. and then we expose and mark the implant site, usually 2 to 3 finger breadth below the left scalp to right side in most cases. So for skin cleaning and antiseptic application, we use chlorhexidine alcohol in most cases. It is the preferred, but some people still use povidone iodine. So when during the cleaning, we apply the antiseptic using a circular motion, starting at the center, then walking outward in the concentric circles. We stop for at least 30 seconds and then we are allowed to air dry completely. We don't wipe or blood. But if you are using povidone iodine, what we do is we first of all use Savlon to clean, then we use methylated spirit, then we use povidone iodine. That one. So for special consideration, patients with diabetic patient, you have to be extra careful with their skin integrity and aesthetic choice so that you not cause burns. And then for base patients, we have to extend your field of preparation. All the skin folds should be properly cleaned. Yes, properly cleaned. Okay, so this is our cleaning process. So our cleaning process with our chlorhexidine in circular motion, moving start from here, then move. Yes. Okay, so the anesthetic we do it under conscious sedation. We give midazolam, or in their case, we give fentanyl. So that is just the procedure in summary. After draping, we give loan anesthetic to numb the area. We create a pocket, we get access through the axillary thoracic subclavian. We put the lead in the heart, we screw it to the muscle and test the battery, then put the device in the pocket created. We still talk about that. This is our cath lab. So this procedure is better done in cath lab because you need to look at those things under fluoroscopy. It's best done in cath lab. This is our cath lab. So this is the draping of the patient. This is our surgical instruments. Sterilized surgical instruments. This is the device. Okay. Okay, for venous access, non-venous access is preferred, usually the left, and it's good to do venogram to see what your access, and you tend to give good IV access on both sides because we can good IV access for venogram and other things that we want to give the patient. So overview of the venous access. We have 3 venous access. Caudal, subclavian, the axillary. What we use mostly in this our cath lab is actually the axillary venous puncture. Okay, because the cephalic so what it does is it direct surgical exposure of the cephalic vein, though it has no complication, but skills, something, the skills involve you dissecting that place and all. Okay, so it has low complication rate though, and less complication of pneumothorax. Or sometimes maybe too small absence if you need cephalic absence. So it has some drawbacks. But subclavian vein puncture risk of pneumothorax is very high, and lead cross syndrome is very high also. Why this axillary vein puncture requires skill, or you may need ultrasound guided, but the risk of pneumothorax is very low in this one, and then they allow you can pass multiple leads here in the axillary venous puncture compared to the cephalic. The external jugular vein can be sometimes be used as backup, but in our cath lab here we use axillary venous puncture or extrathoracic subclavian. Okay, so this just to show us overview, and you can see that the risk of pneumothorax is low in the cephalic vein and the extrathoracic/axillary, while it's very high in the subclavian. And then for the subclavian, for the extrathoracic, you can pass multiple leads. It's very easy. But passing multiple leads in cephalic may be difficult. So ease of extraction, if required, is very easy. So that's why we go for this. So send your patient in. We assure you of the best. Okay, so this is the subclavian roots. We rarely use it. We don't even use it here. This is the cephalic access. Maybe too small. maybe too small, need dissection and all. Then after getting the access, you pass your needle, then you introduce the guide wire and then introduce your leads. Okay, so this is the axillary access. This is the site that we normally use, or the first and second rib. So this is the access site. This is where we puncture. It's usually where the first rib becomes vertical. That's the puncture site. So this is the venogram. So venogram is important to show you your landmark. Okay, so you should do venogram. Okay, so this is axillary venous puncture. It's done under fluoroscopy. That's why I said it's best. This thing is best done in cath lab, so that you see other things. Anything that is going inside your patient should be seen. And how we used to say it's under fluoroscopy. So you identify your first and second vertical portion of venogram. You puncture with 21G or 18G needle, and then you confirm the blood return, advance your guide wire under fluoroscopy. Then you start your sheet under the guide wire and proceed with the lead placement. It's very easy. If you're around Abuja, just come pop in, we show you this. Okay, it's good to mention this. This is the axillary vein puncture. This cavali vein. This is axillary vein before it becomes the subclavian. So this is the junction that we normally use. So we don't use this place because if you use this place, this is the pleura. So if you use this place, you puncture the pleura, then you give the patient pneumothorax. Okay, so this is ultrasound guided. You can see your axillary vein and axillary artery. So you can use ultrasound guided too. So you can see the wire as it's moving from the subclavian into the SVC to the subclavian SVC, the right atrium. So this is the movement. So this is the puncture site. Okay. Okay, so when do we do a venogram? Venogram in any patient with pre-existing leads, you must do venogram to know where the old leads are and where you want to put the new leads. Okay. So it is mandatory for patients with pre-existing. Sometimes we may want to do upgrade. Okay, patient is on CRT, ICD, you want to give them CRT. So for such people, you must do venogram. It's mandatory. And it goes with a patient because of the alarm marks. You may not be able to palpate. So you need to, yes, you need to do venogram for them. For patients with risk of pneumothorax, in case of COPD patients, advanced age, you need to do venogram. When you are suspecting anomalies of the anatomy of the vessels, you need venogram. And then when you implant complex devices, you need venogram. So this is the pocket. So the goal of the pocket is to allow secure sterile placement of the device, avoid infection, hematoma, and skin erosion, and ensure comfortability and position of the lead, because we don't want the lead to be moving up and down. Yes. So not do its function. Okay.
Also for cosmetic.
Yeah, for cosmetic reasons. Okay, so this pocket creation and planning. So this is the pocket that we have created for this patient. What we do is typically is left infraclavicular area about two to 3 finger breadth below the clavicle. So you just make your incision here. Okay. So the layer may be subcutaneous, subfacial, or subpectoral, depending. But this is how we do just to 2 to 3 centimeters, 2 to 3 finger breadth below the clavicle. Okay, so how do we make an incision? So we have said that, okay, 2 to 3 finger breadth below the clavicle, okay, where the second ribs and first and second ribs become the vertical. So you make your incision. After anesthetizing with local anesthetic agents, you make a 4 to 6 cm horizontal oblique incision. And then when you have incised, using the anatomy of blunt dissection, you create a blunt dissection plane under the skin and fat to form a pocket large enough for the generator. So most times here we do a blunt dissection so that we create a pocket that is large enough, because if you create a small pocket, so it won't stay. Or if you create a small pocket, so it must be a correct pocket for the device. Okay, so after that blunt dissection, you can see we are doing blunt dissection. This is the fascia that we have exposed here. Some skinny people, you may even go down to expose the muscle, but this is the fascia. And some people will stop at this level, but some people, skinny people, may go down. Okay. So what we do after that is we flush with saline. The purpose is to clean out blood or debris. We place temporary gauze to just maintain dry pocket while it's at place. I advise you to come around to come and see how we do it. To check for bleeding, low pressure needed before inserting generator. Then we prepare for device insertion, connect lead test, and then insert device into the pocket smoothly, and then you suture. So it's a very clean procedure. It doesn't take time. It doesn't take time at all. So this is the sheet that we are putting inside. So come around and see what we do. This is just to show us that these can be unipolar or bipolar. So don't let me bother this. These are the electrical coil. This is where the patient that delivers shock for the patients. Okay, this is the venogram. This is the venogram, this site of puncture. Okay, this is the lead insertion. You can see the movement of the lead. Okay, so clavia, the ISVC, going to the right atrium, and then right ventricle depending. Okay, so this is when you're about to close. This is how we anchor this anchor the suture to the sleeves, and then the lead to the muscle. This is the way we anchor it. A bit technical, come around. So after all said and done, so we do final fluoroscopy to be sure that your device is in place, because if you are putting your device in the lungs, so you must do final fluoroscopy for the patient. It's very, 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 very important. Okay, so what are the key parameters to measure for each lead? After putting it, so we connect these leads, we connect it to our programmer. So we sense, we do our sensing, capture threshold. All this is to ensure that the device is working well. So for our sensing, atrial sensing should be above 1.5 millivolts. So why does it matter? It ensures that lead can detect native heartbeat. So ventricular amplitude should be greater than 5 millivolts. Yes. For our capture threshold should be as low as possible. And this ensures that person works with minimal energy. So when the person works with minimal energy, the battery of the patient will last. So the capture threshold should be as low as possible, less than 1.0, as low as possible. Then the lead impedance, it should be 300 to 1005. So what this confirms is to confirm your lead integrity. If your lead impedance is less than 300, there is a problem. When it's greater than 1005, there is a problem. Then you do simulation test. Simulation test is to observe, you check it on ECG to see whether there is muscle twitch. And so when you see that, it confirm when the simulation test is okay, then you confirm effective capture and placement. Then the phrenic clamp stimulation also. The phrenic clamp stimulation is very key because it prevents the diaphragm twitching or discomfort, because if you don't do phrenic clamp stimulation, then the patient can be having recurrent hiccups. So when you do phrenic clamp stimulation and you notice that, you know that, okay, this patient may be having this, then this stability is confirmed via fluoroscopy. So that's what the fluoroscopy that we did. So the sensing, we have said that before, the atrial should be greater than 1.5, ventricular should be this. And low signal, when you see, when low signal is when it's less than 0.5, so you need to consider the positioning of the lead. It should be, for atrial, it should be greater than 1.5, ventricular should be greater than 0. So when it's low, know that you need to reposition your lead. When it's large, it's a good tissue contact. Okay, then the capture, we mentioned this also. Okay, so what we do is we deliver person at high input. Okay, so when we deliver person at high input, when we decrease the output step by step, and we find the minimum voltage that still causes capture, so then we have the safety margin. So the safety margin is setting the output at 2 times of the threshold. So don't worry, come around. We teach you a lot about this. Okay, then the impedance, we measure this also. Okay, then the final lead securing. It's good to finally secure the lead so that it prevents migration and dislodgement. Then this allow movement without tension. So then the pocket closure, and then do chest X-ray to see that your device is. So you must always do chest X-ray to see that your device is in place. So conclusion, heart failure is a major global health challenge with hypertensive heart disease, the leading cause. Accurate diagnosis through history, physical examination, ECG, echo, biomarkers, and treatment with GDMT is key. Device therapy is a component of modern heart failure therapy for qualified patients and should be offered when indicated. Device therapy has shown to be effective in improving symptoms and quality of life, reduces heart failure hospitalization, and reducing mortality. Okay, this is greetings from Cardiocare. Thank you for joining us. Put your question in Q&A box. We are here. So these are my references. Thank you.
So we await your questions now. If there are any, just drop them in the Q&A box. Thank you. Okay, we're still awaiting questions from our lovely participants. What listen then? If that means you understand everything.
Everything.
Or understand.
They understand everything. They are sending their questions as from tomorrow. Go to heart failure support group for devices. Ejection fraction less than 35. Your patient needs device, please, to prevent sudden cardiac death.
Yes. So we're still waiting for your questions.
Waiting for your questions.
All right, so thank you all for joining in. My name is James Manuel, and we're talking briefly on the services we offer here at Cardiocare Multispecialty Hospital. I'm sure you have learned so much from today's edition, and so let us go through some of the services that we do here at Cardiocare. So, who is Cardiocare Multispecialty Hospital? Cardiocare is a hospital that is dedicated to cardiovascular and internal medicine. We have received multiple awards for excellence in our service, and we are a support hospital for your practice in Nigeria through our specialized services, research, training, and collaboration. So, Cardiocare Hospital is a hospital that is devoted to cardiovascular care, and we are located at number 5 Giza Close, area 11. So, if you have cases that you need to refer, we are open to it, and you can reach out to us so that your patients can come up good, with good healthcare outcomes. So, we do interventional cardiology. We have a cath lab. We do endocrinology, hepatology, cardiology, nephrology, transplants, and dialysis. So anything that pertains to internal medicine, we do it here at Cardiocare. So once more, thank you for joining. So we are open to partnerships and referrals. So thank you so much. So while we take the questions now, okay. All right, so thank you so much, and let's continue. Thank you. Yes.
So, welcome back.
Welcome back, Dr. Rashidat Oshunlaja. Thank you for joining us and thank you for the question. And so you have the lecture materials. Thank you.
We sent your mail
I'll be
actually.
sent to your mail. Then another, I want to clarify one point regarding rehabilitation. You mentioned that the patient will have risk of sudden cardiac death. Does this level of risk also apply? Yes, any patient with diagnosis of heart failure with ejection fraction less than 35% has risk of sudden cardiac death, irrespective of the age. Irrespective of the age. Heart failure diagnosis, ejection fraction of less than 35% on guideline directed medical therapy for at least 3 months, no improvements. So yes. So we need to find out what is causing the heart failure in the 20s. Is it rheumatic disease? Is it dilated cardiomyopathy? Diagnosis of heart failure, low ejection fraction is a risk for the cardiac death. So that is it.
So, roughly, this procedure, how much did it cost?
Okay. Do you see around Abuja? They want you to come. So
Can meet the front desk.
you can make the front desk. We send the we give you the quotation.
All right, thank you. I'm still expecting more questions if there are any.
Okay, so for the price of the procedure, kindly drop your number. We'll contact you. Our customer care will contact you, please.
So thank you so much for joining this month's webinar. We will do this again next month, same time, last Friday of every month. We hope to bring you more interesting topics and also to, okay, all right, we'll follow that up. The diabetic mellitus foot webinar.
Okay, we'll follow that up, please, Dr. Ismail.
All right, thank you so much. So we'll do this again next month. Do well to join us, and until then, have a wonderful month ahead. Thank you.
Thank you.